Exercise during pregnancy. If the pregnancy is progressing normally, exercise may and should be continued. The amount of the type of exercise is an individual matter. A woman who has exercised regularly before her pregnancy should experience no difficulty with continuing. However, a previously sedentary woman should not attempt to institute a vigorous exercise program such as long distance running or jogging during her pregnancy. No matter what the type of exercise, it is important to remember that with the progress of pregnancy, the center of gravity will change and probably prevent participation at the same level and skills as before pregnancy. Sports to avoid include water skiing, horseback riding, and scuba diving. In water skiing, high speed falls could cause miscarriage due to an inadvertent forceful vaginal douche. In horseback riding, in addition to the possibility of falling from the horse, the repeated bouncing may lead to bruising of the perineal area. Scuba diving may lead to decompression, sickness, and bends and to intravascular air embolism in the fetus. Women who breastfeed their children can continue exercising if they maintain hydration and adequate breast support. Sexual intercourse during pregnancy. Women who are experiencing normally progressive pregnancies need not avoid intercourse. Pregnant women should refrain from coitus if they have history of preterm labor or premature rupture of membranes, and if they are bleeding or have ruptured membranes. Tests during pregnancy. Common tests during blood tests for nutritional or sickle cell anemia, blood type and Rh factor, rubella titers, syphilis, and serum alpha fetoprotein for the presence of neural tube defects such as spina bifida. Ultrasound may be used to determine age, rate of growth, position, some birth defects, and fetal sex. Chorionic villus sampling is done early in pregnancy if the family history indicates potential for genetic diseases. Second trimester amniocentesis may be used to detect chromosomal abnormalities, genetic disorders, and fetal sex. Additional testing may include determining HIV status and hepatitis immunity. In late pregnancy, non-stress tests, contraction stress tests, and fetal biophysical profiles may be done. Amniocentesis may be done to evaluate fetal lung maturity. Pregnancy in adolescents. Although pregnancy among teenagers is decreasing in the United States, about 7% of all American teenage girls still become pregnant in any given year. This is one of the highest rates of teen pregnancy in developed cultures. Sociocultural factors are believed to contribute to the high incidence of pregnancies among this population. Demographic data indicate that the teen pregnancy is more likely to be associated with being single, having low socioeconomic status, and lacking social support system. Pregnant teenagers are believed to be at high risk for some complication of pregnancy. If, however, they seek prenatal care early and consistently cooperate with recommendations, the risk of the risk is comparable to that for other age groups. Clinical data identify a common pattern of late entry to the prenatal care system, failure to return for scheduled appointments, and non-compliance with medical and nursing recommendations. As a result of these behaviors, adolescents are at high risk for pregnancy-related complications such as iron deficiency, anemia, pregnancy-induced hypertension, preterm labor and delivery, low birth weight newborns, and cephalopelvic disproportion. Other health problems seen more common in pregnant adolescents include sexually transmitted disease and substance abuse. See high-risk pregnancy nursing diagnosis appendix. Mature pregnancy. A growing number of women are experiencing their first pregnancies after age 35. The incidence of fetal demise among this population is 6 to 1,000 births, double the rate for women under 35. Many factors may contribute to the increased risk, including pre-existing and coexisting conditions such as diabetes, mellitus, hypertension, and uterine fibroid. Mature women are identified as being at higher risk for spontaneous abortion, preeclampsia, abruptio, placentae previa, gestation, diabetes, cesarean birth, and chromosomal abnormalities such as Down syndrome. Multiple gestations secondary to the use of fertility drugs also may be factor of fetal loss. Pregnancy after menopause. Very rarely, postmenopausal women have become pregnant through embryo donation and have successfully carried the pregnancy to term delivery. Prior to undergoing this procedure, the women had been taking hormone replacement therapy. Previously, it had been assumed that the postmenopausal uterus would not be capable of supporting the growth and development of an embryo. Pregnancies in older women are considered high risk for reasons similar to those related to mature pregnancy. Late in the third trimester, the woman may be instructed to keep a fetal activity record and undergo regularly scheduled non-stress tests. Abdominal pregnancy. Ectopic gestation, in which the embryo develops in the peritoneal cavity. Abdonomyesis. See ectopic pregnancy. Ampulla P. Ectopic implantation of zygote in the ampulla of a fallopian tube. 78% of all ectopic pregnancy occur in this in this site. Bigerminal pregnancy, intrauterine twin gestation, cervical pregnancy, pregnancy with implantation of the embryo in the cervical canal, coitus during pregnancy, sexual intercourse during pregnancy. There is no evidence that this has adverse effects on the pregnancy or the embryo. Example, perinatal mortality. Also, sexual intercourse does not initiate labor. Corneal pregnancy, a rare type of ectopic pregnancy found in about 2% to 4% of all ectopic pregnancies, in which implantation takes place in one of the horns of the uterus. The uterine horn may rupture between the 12 and 16 weeks gestation, causing life-threatening in shock. Traditionally, corneal pregnancies have been managed by laparotomy and hysterectomy, although conservative management strategies are employed occasionally. Ectopic pregnancy, extrauterine implantation of a fertilized ovum, usually in the fallopian tubes, but occasionally in the peritoneum, ovary, or other locations. Ectopic implantation occurs in about 1 of every 150 pregnancy. It is responsible for approximately 10% of maternal death. Symptoms usually occur between 6 and 12 weeks after conception. See Illicit pregnancy.